For the next 15-20 minutes, I'm going to take you through what's really new in device therapy for heart failure. I think what is really new is getting it right the first time, and there's been a lot of talk about this. There's a big thrust on all healthcare professionals to really imbibe the philosophy of doing right by the patient, harking back to what Sarah was telling us about her experience, and that has actually been extended to the devices world, the medical device safety program, which essentially assures the patients that they're getting the best and the safest medical devices. And would you believe it, this was started in consultation with the orthopedic surgeons, and we as the cardiology world are taking on from the orthopedic surgeons. So medical devices in cardiology have been included in here. For the clinicians, it's really about actionable data to improve assurance and make improvements. When we talk about cardiac devices, why are we giving that individual patient that device? Is there a better device for that patient? Can we do it more safely? And I guess finally really deciding, is there a way of optimizing these innovations? It's one thing for companies to come up with fancier and fancier devices. What is the impact of those innovations in true patient world? How does that impact patients like Sarah? What does that really do to the patients? What are we making of that data that comes through those devices? So I think it's a perfect time to readdress the balance between the heart failure world of patients with a prevalence of 1% and this niche world of cardiac devices where very few patients benefit from and get the devices they need. So when we talk about device therapy in heart failure, very broadly, I've divided it into common things that we understand. They can have pacemakers, they can have cardiac resynchronization therapy devices, or the 3 lead devices that Stuart was talking about to synchronize heart muscle function. And then they can have defibrillators, very much about delivering the life-saving shocks up until the ICDs associated with the paramedics and to save patients from sudden cardiac death, the arrhythmic death that heart failure patients die from. Of course, they can have a combination of the two. They can have a CRTP or a cardiac resynchronization therapy pacemaker, which incorporates the bradycardia element, the slow heart rates, but ensuring that they're getting the best of all worlds. They're getting the pacemakers they absolutely need at the time that they need it. So although it's going to treat their slow heart rates, it's going to prevent their heart failure from getting worse. Or they might have a pacemaker defibrillator, which synchronizes their heart muscle, providing the bradycardia element, providing the synchronization therapy element, but very much there with the defibrillator component to prevent the risk of arrhythmic death. So what do we as implanting cardiologists need to know before we implant? So we really need to know, is heart failure reversible? And when I say is heart failure reversible, I'd like to extend that, not necessarily getting the ejection fraction back to 55%, but as has so eloquently been put through by all the speakers before me, has the optimization of heart failure medication, the big 4 in heart failure, has that actually improved the ejection fraction to beyond the 35%? So is that heart failure getting better with optimal medical therapy? And if it is so, then I think we need to persevere with optimal medical therapy and up-titrate as is fit for that individual patient. Is it acquired or inherited? Well, why does that matter? You've already heard from Shabana earlier that heart failure is a very diverse presenting group. So you can have young patients, you can have old patients, you can have really well patients with heart failure, and you can have very comorbid patients. So it really depends on what kind of heart failure this is. It's about individualizing, tailoring that therapy to that individual heart failure patient. So if it is an acquired condition, is this heart failure related to a rapid atrial fibrillation, for instance? Or is it heart failure related to thyrotoxicosis that's going to be reversed? So is this something that you're going to treat is going to get better? And that's a different management for heart failure. So the big 4 still count, but you're going to try and reverse the conditions that have contributed to the heart failure. Or is it inherited? Well, there are conditions that are passed on from genetically from generation to generation, the lamins, the titans, the big genetic conditions, the HCMs that go from family to family, younger patients, and we really need to know that because the focus of how this heart failure is going to evolve is going to be different, and therefore what the kind of device that patient is going to get is also going to be different. For instance, in a patient with a lamin inherited condition with heart failure, we might have a much lower threshold for offering them a defibrillator because their risk of sudden death is so much higher than your average heart failure patient. So appropriate time and therapy, timing and type of therapies, and this we've already been through and you've heard all morning about how really the big four, heart failure needs to be diagnosed in time, treated in time. And the paradigm for treating heart failure is really changing. It's not the usual stepwise approach. It's very much throw everything you can, even if it is in small doses, and uptitrate as they tolerate it. And finally, Stuart's already mentioned this prognosis. It's about tailoring that approach for that individual patient. At where are they in their heart failure journey? Are they in the troughs? Are they in their peaks? Is this the right time for the right patient, for the right device in that journey of heart failure? So pacemakers, I'm going to concentrate on pacemakers to start with. So when a patient with heart failure needs a pacemaker, remember this is about getting it right the first time. So the questions we really ask ourselves is he likely to pace? So if the patient just needs a backup pacemaker for the odd time that he's going to have a long pause, then he really needs the simplest possible pacemaker, just as a backup, just to support his heart rate on the odd occasion he's going to need it. Which chamber is he likely to pace? So is he going to pace the atrium, the top chamber of the heart, or is he going to pace the ventricle? We know historically that pacing the right ventricle is very detrimental to the heart failure patient. So if you have a heart failure patient who's bradycardic enough to require right ventricular pacing, think about what kind of pacemaker the patient's going to get. We certainly do. Does he need it for rate control? And this, I'm pleased to say, extends to those patients with preserved ejection fractions. So AF, as we've already talked about this morning, is very, very common in the heart failure population. So a third of our population at some point in their heart failure journey will develop AF or might have had AF. And so if you're going to need a pacemaker to control their heart rates because they've got a tachybrady, so they're too fast at times, too slow at times, they might require a pacemaker. And it's worth considering, and I'll show you some really startling evidence in the atrial fibrillation population. And finally, I guess, how poor is his ventricle? If he's got a preserved ejection fraction, he might do better with a simpler pacemaker. If he's got a poorly ventricle, if he's got low ejection fractions, he's much more likely to benefit from the more complex cardiac devices we have to offer. And this was a hallmark study. I won't take you through the nuances of the study, but basically this was a study which looked at patients with low ejection fractions and heart block. They included first degree, second degree, and third degree AV block. And it was about 750 patients, randomized them to standard pacing versus CRT. So essentially all patients got CRTs, but some of them had RV pacing and some of them got biventricular pacing or cardiac resynchronization therapy pacing. And as you can see, the Kaplan-Meier curves are diverging as early as 3 to 6 months. So pretty early on, it was obvious that those patients who got synchronization therapy pacing did better. So this is primarily a bradycardia pacing population. So this is not a heart failure population. This is bystander low ejection fraction, okay? So it's a slight difference, but in patients who required a pacemaker and had bystander heart failure, they did better with CRT. And that made it straight to the new ESC guidelines, the new era guidelines, saying that CRT rather than RV pacing is recommended for patients with HFrEF, as defined as an ejection fraction less than 40%, regardless of NYHA class, when you think the patient's going to pace. And that arbitrary figure of the patient's going to pace has been dropped on the new guidelines to just 1 in 5 beats, 20%. It used to be 40%, it's been dropped to 20% now. So you don't need much pacing before you're starting to consider a more complex device. And this is pretty much hot off the press. It's only been released in August this year. So. Atrial fibrillation, the heart failure person's least favorite arrhythmia. So it's really a common condition. We've talked about this, a third of our patients. There's no getting away. If you look after heart failure patients, you have no choice but to address atrial fibrillation, even if you didn't want to. So there's been a lot of talk about the right heart failure patient being offered a pulmonary vein isolation to establish sinus rhythm. I think there's no doubt in any of our minds that if you can have sinus rhythm, it's a much better rhythm for the heart failure patient. And that extends not just to medical therapy, but also to pulmonary vein isolation. So also have a low threshold for considering a definitive rhythm management strategy for the heart failure patient, especially if they're early on in their diagnostic stages or in their evolution of their disease, early on in the disease, consider reestablishing sinus rhythm. The other big question is, what is a reasonable resting rate for the AF patient? And I would say that the increasing evidence is that a resting rate slightly higher, anywhere between 70 and 90, is probably the optimal rate for the AF patient. So when you get your 24-hour Holter monitors, for instance, have a look at the mean rate before you can decide if this is enough for the patient. So lower is not better in AF for the heart failure patient. And finally, of course, there's no need to tell any of you that these patients have a very high CHATS-2 VAS score. They are at risk of thromboembolism, so addressing their DOACs, addressing their thromboembolic prophylaxis is really paramount in this group of patients. So this was a really interesting study called the APAF-CRT study, and this is really, it's only been published a few months ago, and it talks about the AF population. And so to get into this study, albeit a small study, 133 patients with permanent atrial fibrillation needed to have one heart failure hospitalization in the preceding 12 months. And if they did, they were randomized to either rate control, which was an ablation, an AV node ablation and a CRT, or to optimal medical therapy. Both groups were anticoagulated, as you might expect. And essentially, patients who got the AV node ablation with the cardiac resynchronization therapy had a much improved mortality and morbidity, reduction in heart failure hospitalization and mortality. And a bit like the numbers Shabana showed you about optimal medical therapy, the number needed to treat in this study was 4. So you only needed to have 4 patients with AF and a heart failure hospitalization to be offered a CRT and an AV node ablation to actually save one life. Quite dramatic, I would say, for a 133 patient study which was randomized. Straight off the press, but it came out after the ERA guidelines, so it hasn't made it to the guidelines. So when is cardiac resynchronization therapy an option with AF? So patients with heart failure, HFrEF, and A-bundle branch block, and patients with uncontrolled heart rates who would benefit from an AV node ablation. So as I mentioned, AV node ablation is starting to come back in favor again after the APAF-CRT study. Ventricular arrhythmia is the bane of every cardiologist's life, every heart failure patient's lives, and clearly every heart failure nurse and physiologist's lives too. So correction of the usual electrolyte abnormalities, the low potassiums, low magnesiums, the stuff that our diuretics are very commonly fond of creating for our patients, withdrawal of agents that might provoke arrhythmias, and Dennis alluded to that in his talk. There are drugs that the heart failure patients really don't like. And the antidepressants are a big culprit in this. You can have the NSAIDs. There are all sorts of drugs that interact with heart failure patients' medications that contribute to comorbidity. And I don't think it's enough in this meeting to stress the big 4 in heart failure, the SGLT2s, the sacubitril valsartan, the beta blockers, and the MRAs. So optimizing these patients is going to be the cornerstone for managing even ventricular arrhythmias before you do anything about devices. And clearly adding on SGLT2 inhibitors to the current regime is absolutely important. Myocardial ischemia, Dennis has already mentioned this. Do they have chest pain? Do they have grafts? Have they had a stent previously? Is this what's driving the ventricular ectopy? Is this what's driving their increasing decompensation? A question needs to be asked before we do anything else. And finally, of course, this is what I'm here to speak about, is defibrillators. So you would hear there's a lot of, I think, confusion and perhaps misinformation about the lack of need for ICDs in the non-ischemic heart failure population. And I thought this was a good forum to address the reality of it. The study that was done very well was called a Danish study, about 1,200 patients randomized to optimal medical therapy. And by optimal, I mean really high-class medical therapy, to the point that 54% of the medical therapy included CRTs. So that's how well the patients were managed. They were randomized to ICDs or no ICDs. And these were non-ischemic patients. So they were angiogram negative, non-ischemic patients with low ejection fractions. And across a follow-up period of nigh on 6 years, there was no mortality benefit with ICDs. And the study was accompanied by a few editorials with very important subgroup analysis, because obviously you don't want to throw the baby out with the bathwater. Sweeping generalizations are the bane of the heart failure patients' lives. And I think it's very important, as I said, to tailor therapy to individual patients. So within this group of non-ischemic heart failure patients, there was clear benefit for younger patients. So patients under the age of 60, improved but also benefited significantly in terms of mortality for the ICDs. And the editorial went on to say, they talked about competing comorbidity. So they said if the patient was likely to die of other causes, then an ICD would not reduce his mortality. And that is common sense to all of us heart failure professionals in the room. So that makes perfect sense to us. This is a really interesting slide. It took a little bit of digging to get to this, but this is a longitudinal look at all the heart failure studies done thus far, 40,000 odd patients over a 19-year period. And I show you the slide a little bit like Stuart's slide for the medical therapy. This includes all the medical, but it looks at specifically sudden cardiac death risk. And right at the beginning in 1990s, the sudden cardiac death risk, this is annualized sudden cardiac death risk, was 6.5%. And there is little doubt that just good quality heart failure medication has dropped even the arrhythmic death risk, sudden cardiac death risk, significantly. It has dropped it, so in the paradigm study it was 3.3%, and I suspect it's dropped by another percent with the addition of SGLT2 inhibitors. So despite that, however, there is a cohort of heart failure patients whose sudden cardiac death risk is over 1%, and that's the arbitrary cutoff for the point at which these patients benefit from ICDs. So it's just that figure, if you keep it in your head, it's about 3.3% across all categories of heart failure patients with low ejection fractions. This is purely sudden cardiac death, arrhythmic death risk. So I just think it's a really interesting to understand how the changing face of heart failure medication has transformed mortality in the heart failure population. There was a clinical practice update released a couple of years ago, and I think it was quite a pragmatic update, which is why I brought it up here. So one may consider not to implant an ICD in the non-ischemic HFrEF patient if they were elderly, if they had advanced heart failure symptoms, as in NYHA 3, 3, 4, or they had a life-shortening comorbidity. And that's pretty much what we've said all along. If we think they're going to die of other causes, then perhaps shoving an ICD is not the right thing for them. And the benefit of ICDs is determined by the risk of sudden cardiac death over the risk of non-sudden cardiac death. This is the ICD guidelines on the ESC Heart Failure Summary, and very much the same as the 2016 guidelines. Not very much has changed. On the right side, on the left side for you, the secondary prevention, if patients have been lucky enough to survive sudden cardiac death, then clearly, unless there's a good reason not to, you ought to be offering them an ICD as an inpatient, which is what happens for most patients, unless that sudden cardiac death was related to a treatable event, and the treatable event has been treated definitively. So, and the context would be, an example would be an occlusion of a left main stem or occlusion of an LAD. Patients are presented with VF, but they've come in as a primary PCI, the LAD's been opened, and you're happy that that was the cause of the VF. You move on to the primary prevention, which is pretty much where we'll be seeing patients in the communities. NYHA 2, 3, so you want the stable heart failure patients, you want a low ejection fraction, you want optimal medical therapy, and if they're ischemic and 40 days post-MI, then it's a class 1A indication. If they're non-ischemic, that indication class has dropped to 2A. So it used to be a 1B on the old guidelines. But following on from Danish, this is a nod to Danish, they've dropped it to 2A. It's still very much within the guidelines for the non-ischemic population, but it's just been dropped to a 2A. Finally, coming on to CRT, a third of your patients across heart failure should have a widened QRS complex, just to set the scene, and this sort of highlights the importance of a 12-lead ECG for those community heart failure patients. What you don't know, you don't know, and unless you've got a more recent ECG, you're never going to know. So sometimes patients, when we go into the heart failure clinics, patients have not had an ECG for God knows when they had their last ECG. And I think that's the reason, because if you have a wide QRS complex, there are other things we can offer them that can improve their quality of life. So CRT patients in sinus rhythm, essentially a low ejection fraction. We're still very much obsessing on the ejection fraction in the devices world. It's to do with the trial evidence, so ejection fractions less than 35%, wider the better. So we want wide QRS complexes, preferably greater than 150 milliseconds, and a left bundle branch morphology. So you really want a wide QRS for a 1A indication, and if it's less wide, between 130 and 150, it's a 2A indication. The indication class drops. Again, this is slightly different to the previous arrhythmia guidelines, where you just needed a QRS duration of 120. CRT is definitely now off the cards for QRS duration of 120. Non-left bundle branch morphology, again, the main thrust is the indication class has dropped. We're very much telling the patients that left bundle branch is the right kind of bundle branch to benefit from CRT. We'll offer it to people in right bundle, but the benefits are less clear, partly because patients weren't included in trials. What about upgrades? There are lots of patients out there who've got pacemakers in situ, just standard dual chamber, single chamber pacemakers. We should be considering upgrades in these patients if they have a low ejection fraction, if they're symptomatic heart failure, and if they have a significant proportion of RV pacing. So the first question I'll ask you is how much are they using their pacemaker? So if it's over 20% RV pacing, then I think we're starting to think about perhaps offering them an upgrade. So just to understand the information we would want when referrals come through for a cardiac device. We've touched on this before, CRTP versus CRTD, making the right, getting it right the first time for the patient, the kind of device you're implanting is the right thing for that individual patient. Factors in favor of CRTP rather than CRTD, non-ischemic cardiomyopathy, short life expectancy, major comorbidities, poor renal function, patient preference. And I think the real oversight of all of these nuances only happens at an MDT, where all of us sit around the table or across Zoom, as is currently the case, and we discuss that patient. Everybody gives us the input, and we say, actually, maybe P, maybe D. We're trying to make that decision for that individual patient. Prognostication, Dennis has already touched upon it, Stuart's touched upon it, really important. As the heart failure patient deteriorates, deactivating of the patient's ICD is appropriate. Discussion is important. Family support is nice, but it's the patient's choice if the patient has capacity. If the patient doesn't have capacity, we're getting into an independent mental health capacity. You're talking about your lasting power of attorneys, just to get it right for that individual patient. It's the same when we're replacing ICDs. We have a lot of time spent by myself and my heart failure nurses discussing if it is the right thing to do for that individual patient. An awful long time is spent just deciding whether we should be box changing that patient or not. So going back to GIRFT, it's really about education, it's about communication, it's about feedback, and it's about team working. And really none of us have the complete picture, and unless we all work together, it's going to be nigh on impossible to get it right for that individual patient the first time. So thank you.